So Dr. Singal, thank you so much for joining us today. I have a couple of questions for you on this interesting article, a very important area on how we can do better in the management of alcohol use disorders among patients with alcohol-associated liver disease in the liver clinic. So first question for you is that why is screening for alcohol-associated liver disease important?
Yeah, thank you, Dr. Leon Pascal and AASLD and Clinical Liver Disease for this opportunity. And I want to thank you, Michelle, also for coordinating and arranging this. It's a good question why it is important. I think we all know that alcohol-associated liver disease is one of the leading etiologies of advanced liver disease like cirrhosis, complications, alcohol-associated hepatitis, which are relevant in causing higher healthcare burden, mortality of the patients, need for transplantation. So, for example, there are about 1.5 to 2 million cases of cirrhosis from alcohol worldwide. In the US, hospitalized patients, every other patient is an alcohol-associated cirrhosis, and it contributes to almost 40% of all transplant listings. And so it's a huge burden. Now, when we come to patients who have advanced liver disease like cirrhosis or alcohol-associated hepatitis with jaundice, it turns out that most patients, when they present compared to, say, NASH or hepatitis C, they present at an advanced stage from alcohol for some reason, whether it is a patient-level barrier or a clinician-level barrier in referral of these patients at an early stage. And I think that's the important piece of your question is we need to recognize this disease early on before they progress. And we can do something to prevent a progression to advanced forms. I think from those angles, I think this is a relevant disease to talk about here.
Thank you so much. So with such a prevalence and the burden that you just mentioned, so how do you screen for at-risk persons or patients for alcohol-associated liver disease then?
Typically by two tools. One, which is mostly used in the addiction world, is the DSM-5 criteria for alcohol use disorder. That usually does not talk about quantity of alcohol used, but mostly talk about the physical, the social, the occupational, or interpersonal impact of alcohol use. So I think in a primary care setting or in an internist or a gastroenterology or hepatology healthcare encounters, a more appropriate screening would be using what is called an audit C, or alcohol use disorder identification. It's a brief version of a full audit, which is a 10-item, which is more difficult in a primary and in a busy clinic. But the first three questions is just addressing that do you engage in drinking alcohol? And then if the answer is yes, then you go to the second question, which is at a given time, how much alcohol or number of drinks you take. And if they quantify that, and then the third thing is if these number of drinks on a weekly or a monthly basis, how many days in a week or a month you will take. So that gives you an approximate average intake of alcohol. And there are two catch points here. One, that when the patient says, I take 2 drinks or 3 drinks, it is important for us to clarify with the patient what actually he means by a drink. You know, typically NIH defines a drink as 12 ounces of beer or 5 ounces of wine or about 1 to 1.5 ounces of hard liquor. And once we have clarified that information from the patient, then we can kind of screen at-risk population easily, because in a man or a male, adult male, anything which is 3 or more drinks per day or more than 14 per week. And in a female, 2 or more drinks per day or more than 7 per week on an average is a harmful alcohol use, and that is an at-risk population.
Now, if you see patients with excessive alcohol use, how do you screen for liver disease in these individuals that have a harmful use of alcohol?
It becomes prudent for us, even in those high-risk patients, before we attribute the whole etiology or the whole impact on liver disease is due to alcohol, that we have to rule out other liver conditions, autoimmune, Hep C, Hep B, and we all know what are the serological markers, testing we can do to rule out other things. So we have to have identified high-risk population, rule out other liver diseases, and establish that there is a liver disease. I think that's the important part. Not every at-risk user will have liver disease. We know that only about 20 to 25% of patients may actually end up getting a liver disease from high drinking. And there are a host of other disease modifiers. Gender is one of them. Females are more susceptible. I'm not going to go into those details because probably outside the part of the discussion today. But 2 simple baseline tests if you do in high-risk population. One is ultrasound of the liver to look for fatty change, and liver biochemical test to look for any elevation of liver enzymes, which typically in an alcohol-associated liver disease would be AST more than ALT with a ratio more than 1.5 to 2. And so AST-ALT ratio more than 1.5 to 2, AST higher than ALT, elevated liver enzymes, and or steatosis, then you have identified a group of patients who have liver disease.
Thank you. And one last question. As a practicing hepatologist, how do you manage these patients with asymptomatic alcohol-associated liver disease?
I think there is an opportunity here with the addiction folks, because addiction medicine people get these patients who may not have symptoms from liver disease, but they get them for, say, for example, for control of alcohol use, treatment for alcoholism or alcohol use disorder. And I think if they identify patients who have liver disease using the tools which we just talked about, ultrasound and liver test, if there is a liver disease, I think it may be important for them to integrate with hepatology, especially in patients who have advanced liver disease. So I think the best, like any other liver disease, fibrosis is significantly important to clarify who has an advanced disease, who doesn't have advanced disease. You can't biopsy everybody, so you might use some non-invasive testing, for example, FIB4, enhanced liver fibrosis score, and or FibroScan to suggest. Sometimes there could be, even without doing these tests, you may see some telltale evidences of an advanced liver disease. For example, there could be low platelet count. There could be ultrasound showing some irregular nodular livers. There could be very subtle signs of cirrhosis like muscle wasting, spiders on the chest, gynecomastia, palmar erythema. So if you see all those as an internist or a primary care, you suspect this patient has cirrhosis. And all patients, even asymptomatic who have cirrhosis, should then be sent, I think, to a hepatology or a liver clinic for further management and follow-up of these patients. But then if they don't have telltale evidence of cirrhosis and you do FIB4 or FibroScan or a combination, I will take FibroScan being more important. FIB4 cutoff to say advanced liver disease in alcohol. In NASH, we take about 1.67, 1.7. I think in alcohol, the cutoff is about 3.25. So anybody above 3.25 is a highly suspected of advanced disease, should either have a FibroScan or refer to hepatology for a FibroScan. On a FibroScan, the experience of FibroScan in alcohol is not that much as we have in NASH or other liver disease, Hep C. But based on about 1,100 patient individual pool meta-analysis, the cutoffs for F3 was about 12, for F4 was about 15. So I would say anything above 12 or above on a fibroscan should go to the hepatologist. But here is a small caveat I want to mention here, Sudhar, that the FIB4 as well as fibroscan interpretation may be taken a little bit with a pinch of salt if the patient is actively drinking alcohol. So the fibroscan values, you will be surprised, may be confounded quite significantly. So typically, it is better to repeat these fibroscan values after a week or two of abstinence, and then that would be the truth. And if that is above 12, goes to hepatitis.
Well, thank you so much, Dr. Singal. And again, on behalf of the guest editors and the clinical liver disease team, and thank you again for your time today. For more information about this topic, please refer to the full article by Dr. Singal on the AASLD website, Clinical Liver Disease, on screening for alcohol use disorder and monitoring for alcohol use in the liver clinic. Thank you so much again for your time spending with us today.
And I would like to thank everyone again and also acknowledge my co-author, Dr. Anand Kulkarni, who helped me develop this article, and I'm speaking on behalf of both of us.
Thank you so much. Thank you.